So it looks like we are missing just our subcommittee chairs and members other than Representative Nuccio. Oh, here comes one chair right now.
Can't tell.
Senator Lesser.
Cannot get this to hook up.
Hello.
Oh, Emily, we can hear you.
Sorry.
You're good.
I have a new
Hello.
setup. I'm trying to figure it out.
Senator Lesser, are you running the show this morning?
Well, maybe by default, I'm waiting for, would love to see if Representative Gilchrist is around. I actually asked her if she could chair, but I haven't heard back. If not, I will.
We have 2 hours allotted if we need. I don't know how long DSS has.
Yeah.
But
We haven't seen DSS in hours.
We do
So
have 2 hours allotted.
Okay. So we can
So
wait
We'll wait a couple minutes
if you'd
just
like.
to see.
Mhm.
Good morning.
Good morning.
Good morning.
Okay, should we get Jillian, are you able to chair? If not, I can.
Yes, I can.
Okay, great.
Wonderful. All right, why don't we jump right in?
Okay. So good morning, chairs, ranking members, and distinguished members of the Appropriations Committee. My name is Chantel Vars. I'm the Deputy Commissioner for Department of Social Services, Finance and Administration. Commissioner Barton Reeves could not be here today, and so I am joined by the team and our subject matter experts to answer the questions that we received through subcommittee. And so how would you like to do this? Would you like us to just read the question and then summarize our answer and take questions in between?
Yes, let's do it that way, please.
Perfect. Okay, so we'll go ahead and get started. We tried to group the questions in chunks. And so first up are our questions regarding CFC. We have several questions. And the first question is, what steps need to occur to implement the proposed policy change? Go ahead, Christine.
Good morning, everyone. I'm Christine Weston, Director of Community Options. I'll be talking through most of the CFC questions, and then Anne Marie Casey will also support some of the fiscal questions. But for this, what steps need to occur to implement? We've been talking a lot about this, that it's a transition in authority, right? So we're not closing self-directed PCA services, but we're just kind of controlling the federal authority that we operate under. And it's going to take a lot of coordination, right? So we have to work very closely with CMS, and we have to work very closely with our stakeholders, our sister agencies, DDS, DEMIS, SEIU at 1199, as well as the advocate community. So we do plan to bring in a team to help support this transition. We're going to have programmatic and fiscal expertise to come in with HCBS Medicaid programs. We're going to hold stakeholder meetings. Our first formal stakeholder meeting is next Friday, where we've invited a lot of the individuals that have provided testimony and have raised questions to us. We also have a comprehensive FAQ that's about to be released, a legislative level one, and then we're creating a very much more digestible one for the public. But the self-directed PCAs will remain available during this transition. We're not abruptly cutting applications. We're not abruptly cutting access. So over this whole time, the program will remain open and operating while we do this full coordination across stakeholders, advocates, the Medicaid members, and again, our sister agency partners in 1199.
Okay. The second question refers to agency-based costs versus CFC costs. Anne Marie, do you want to talk to the chart below?
Hi, I'm Anne Marie Casey, Principal Cost Analyst for Department of Social Services. Here we're showing the cost of agency-based PCA services versus the average cost of community first choice services, with the agency-based services include the care management cost and the cost of the PCA services, with the per member per month cost of $4,335. And then community first choice includes the care services plus the fiscal intermediary costs as they are needed to provide the service of $5,521 per month. And then the graph below shows the community first choice utilizing members per month for 2017 through 2025, with projections for 2026 and 2027. As you can see, the enrollment trends are significantly increasing over time and projected to continue to do so.
Thank you, Anne Marie.
Can I ask a question back on that chart? Not this one, the one prior. Between the difference between the agency-based and CFC, right? I have had nothing but complaints from people about GFI, like the people who administer. So does that fall under agency-based? Like, what are the two different classifications here?
Would you like me to answer that, or?
Go ahead, Christine.
So GTI is what's called our fiscal intermediary. And at the end of this, our last set of questions go in depth about what the fiscal intermediary does. But the fiscal intermediary processes payroll on behalf of the CFC participants. So that's second line. And they do not process anything for agency-based services.
Okay, so what is the agency-based services then? What are the difference between the agency-based services and the CFC?
Okay, so agency-based services are where a member would reach out to a home health provider or a home care agency and say, you know, I'm looking to bring in agency-based PCAs to care for me or my loved one if they're helping someone provide their care. And the agency gets assigned, and they are the Medicaid provider, and they bill and they handle scheduling, hiring, and billing. Yep. CFC is a self-directed
right,
consumer model where the Medicaid participant or someone they designate does the hiring, training, firing, and payroll and signing of timesheets. We need a fiscal intermediary to operate all of that for the Medicaid participant, and that's what falls under CFC.
So the per member per month cost between these two is the total cost, which I'm assuming is the claims cost, plus the either care management cost or fiscal intermediary, correct? It's the combination of the two?
Yes.
Okay. So it just looks, I know there's higher people in the agency-based, right? But it looks like it's more cost-effective to go with the agency-based rather than the CFC. Is that what the waiver is going to do? I'm just trying to kind of wrap my head around.
So I think the primary difference in this is the Medicaid reimbursement rate for the two services. So the self-directed PCAs are represented by 1199 in a collective bargaining agreement, and they have a different Medicaid rate and a different wage than what agency-based providers are. So I think that's probably your biggest difference. I don't believe the FI costs would be layered on here in an additional value for self-directed to probably make it even higher. So when we transition to the waivers or another authority, self-directed will remain an option. So those individuals will have higher wages. They will have, the workforce of self-direction will remain available to people, but they will also then have the availability of other services offered under the waiver. Right now, community first choice, if you're not associated with a waiver, you have one service type, which is self-directed. If we move these individuals into a more like comprehensive service package, they'll have choice among their services.
Think I'm getting it. Do you guys have more information on this going through? I'm assuming.
We have more information on the fiscal intermediary, and that's at the end where we go in depth about exactly what they do, the services that they perform, and how it all works. But if you have other specific questions, we can take that back and provide you some response, Rep. Nuccio, if that works for you.
I appreciate that. Thank you.
Thank you. I have a question. So with the governor's proposal to move CFCs to waiver, is agency-based remaining an entitlement, or would that too move to a waiver and have a waiting list?
So agency-based is not an entitlement at this time. It is
Okay.
only in the waivers. So more individuals will have access to that service than previous.
So, Jillian, can I
Yes.
jump in?
Yep.
So I guess I've heard that, right? And I heard that yesterday in the Human Services hearing, and I'm still not following, because as I understand it, you could do agency-based today using the CFC option rather than going to the waiver program. So I'm not sure why we have to do this to bring in agency-based care. I'm still not understanding that. Second, what we heard yesterday and what we've heard before is that one of the underlying problems of the program is deficiencies in the MMIS system that's resulting in consistent, incorrect payments to GTI from the intermediary. I think 2 years ago this came up. DSS hasn't made the investments in MMIS, and what would those be? I know that there's a lag time in making those investments, but how much money does that entail, and how long would that need to happen? And would we need to make those investments regardless of whether or not we switch to a waiver program?
So I'll take the question regarding the investments of the MMIS. We continue to roll out different modules on the MMIS, because we are moving over to CT METs. And so those modules are rolling out, every few months. We have a few rolling out over the next several months. The cost, I'll have to come back to you and get you the cost as to how much it is that we are paying. But I think the issues that you're discussing happened when we were transferring FIs, where there were some billing issues and making sure that the coding was correct. But Christine, do you want to take the questions regarding the agency-based?
Yeah, so agency-based, our current limitations in implementing that in community first choice right now are MMIS limitations, as I indicated yesterday. But there's some nuance behind that, and I want to take kind of your whole question, because I don't want to just answer a piece of it and then not give you enough detail. Also, the talking points that are very much close to being shared are going to really help outline like why it's not just recommended to kind of fix CFC and add things, and really, like we said, look at HCBS holistically and how we can support all members better than just trying to throw services or money into this other program. But I think those talking points will help there. And I think the additional conversations with the commissioners and OPM will help kind of shed some new light on that. But I don't want to speak to that right now until we kind of have that fully like in writing to everybody.
So the document that Christine is referencing, that the department is coming up with a FAQ document to answer some of these questions, and it is under review. And so as soon as that is completed, we will send this out for your review and questions.
Will it come to us here on appropriations also?
I do know it will come to OPM, and then I believe it will be released to the legislative body.
Okay, because Matt and Jillian, I'm not on your committee. If you guys have been, was there a meeting, like, do you have a date of a meeting where you guys may have talked about this in more detail? that I
Yesterday.
can go back and watch yesterday? Was it just a regular committee hearing?
Yeah, it's just a committee hearing, and by the way, we'll have another hearing on this issue next week, I believe. So we're like, this is an active issue. So come and join the Human Services Committee. We'd love to have you.
No. So 3-3, you had Human Services, and next week you're gonna have another one, and specifically about this? Okay.
Yeah.
I'll look for it so I can go back and watch it.
Mhm.
Thank you.
So we do have 4 other questions related to CFs. Oh, I think we have more hands.
I was just going to ask the question that I asked yesterday, Mr. Chair, if I may. Has
Jillian's the
DSS,
chair.
Go ahead.
I'm so sorry, Madam
Okay.
Chair, I only see Matt on my screen. So if I may, I had asked the question yesterday, has the agency ever taken something that was part of our state plan and moved it to a waiver where it would cause a wait list like this? And I'm just wondering what the precedent is for this sort of program to move to a waiver program.
So that's something we'll probably have to take back. This was a state plan option, the 1915K authority under the Affordable Care Act. So this was brand new to Connecticut when we did it over a decade ago. We had the services historically in the waiver already. We moved them for a number of reasons into this other authority, in 2014. So it's a very interesting space for update in that, we had the service available under the waiver. We made it available under the entitlement. And then right now we're just thinking that it would be much better served under the waiver again. So we'll get you the historical information on that question. I don't have that on the top of my head.
Okay, thank you. Thank you, Madam Chair.
Walker, do you have a question?
Yeah, I was trying to find the thing to raise my hand, but I'm raising my hand. So basically I'm looking at your table, which I think is great because now I see the actual costs per capita per person for 4,300. So when you per month, when you say that is that the cost just for the CEA, or are other things built into that cost? I say the care PCA. I'm sorry, PCA.
I believe there are other services. Anne Marie, are you able to elaborate on other services that's built into that?
Under the agency-based, it is purely the PCA services. Under the CFC cost, there may be some meals and PERS, personal emergency response built into, along with the self-directed PCA costs.
Okay, and when you say the PCA cost, is that the healthcare and everything that goes on with it, or is it just that salary?
Just the personal care services cost, not the total Medicaid cost for the person.
Okay.
The salary.
The salary. Okay, all right. And in looking at the 1915 waiver, those things were covered, and the things that were covered under the 1915 waiver were just the PCA's costs. There was nothing else in there, correct?
That is correct.
Okay. Going forward, what you are the CFC that you have down there. What is CFC? Please tell me. I'm bad with the alphabet. What does that mean?
Community First Choice.
Okay, this is the program itself.
Yes.
So under the program right now, the total cost is less than the agency-based costs. Is that because we're paying for administrators for the agency?
That's because there are fewer participants choosing community first choice rather than agency-based PCI.
Okay. All right. And the reason why I'm asking, so when we are looking at the waivers that we're looking at are going to be able to acquire the things that we're doing now with the CFC and that, or are there things that are going to be lost in translation?
The services that are available in Community First Choice would be moved into the waivers along with
And
the participants.
so there'll be all of the things that are in the Community First Choice now.
Yes, additionally, there would be additional services that are also offered in the waivers. So the people transitioning would have greater choice of services.
Mhm. And do we know what those services would be?
That varies a bit depending on the waiver. So the acquired brain injury waivers offer slightly different service packages than, say, the elder waiver.
Mhm. Okay, okay. I'm
So
sorry.
Representative Walker, if you'd like, we can circle back and give you a listing of what would be included, additional services, if that
That would
be
help me.
helpful.
That would help me
Yeah.
because and when we cost this out, when did we, okay, first of all, how much of this is Medicaid reimbursed?
So moving to the waiver, we do lose Medicaid reimbursement. Moving CFC to the waiver.
We
You
lose,
lose it?
Just the enhanced match, DC.
Just the enhanced, sorry, the
Well,
the
that's
enhanced
6%.
match.
just the
Yes,
6%, just
Yes.
the 6%. We still retain the 50%.
correct.
So the total cost, is that including the Medicaid match?
The total cost is the gross cost. It includes the federal share.
Okay.
I'm confused. So I thought when we were talking before, you said that we only got a 6% match on CFC. So
That's the enhanced waiver.
right, that's what I thought, like, that's what, so are we getting Medicaid match on both agency-based and CFC? And if so, what is it?
So we do get Medicaid match on both. On the waivers, we get a 50% match. On Community First Choice, we get 50% match plus additional 6% match.
So we'd be losing the additional 6% match.
Correct.
That
But
is
you think somehow you're gonna make up that savings somehow, somewhere?
Due to trend enrollment, we the match that we get, it's outpacing based on enrollment and costs. So the 6%, we based on the changes that we would make, because we're trying to curb, we're trying to keep cost in line.
Go ahead. You can
the
say it.
match for the cost far outweigh the match that we would receive.
Okay.
That additional 6%.
Okay. So
And
you're
so
saying-
I don't know if showing that bar graph where we showed the increased enrollment, thank you, Dave, where we showed year over year, the enrollment that is taking place, we're also noting that the enrollment continues to increase.
Wow, I feel like I'm
So
looking
from,
at,
yeah, so from 2017, you can see, over 10 years, this has been the enrollment growth that the program has, that has happened within the program.
Can I
so,
ask a philosophical question?
Yeah.
Like, Tony, I don't know if you're going there too, but like philosophically, I think the fact that we're seeing so many people increase wanting to be on this waiver rather than going through the agency route, what does that tell us about the services that people are utilizing or want, right? And if we are going to be curtailing that by moving them to listen, there's nobody on this call that will agree more with you on we have to control our expenses and we have to understand how it's being spent in that. But my concern is that what are the major differences between the agency program and the CFC program that people are overwhelmingly going to the CFC program? And one of my concerns is our governor has very frequently pushed on the aging in home, all of the things where, it's cheaper to keep people at home than it is in nursing homes and that. And I wholeheartedly, like, he and I could not be in any more agreement on that one. But is this going to prevent that? Because I think, these services are the services that people who are trying to stay home are using. So that's why I think I need to go back and listen to Jillian. I need to go back and listen to your human services to see if you guys have more details in there on that. But I think I've got some fundamental questions that I would like to understand.
So can I interrupt for 1 second?
Please do.
Representative Nuccio, Representative Walker, and chairs, we understand that. We understand that there are a lot of questions regarding the transition of CFC into the waiver program. And one of the things that we are working, to Christine Weston's point, one of the things that we are working is making sure that we have that sheet FAQ so that we can answer these questions satisfactorily to you all. And I would ask that if you can give us just a few more days, we can definitely get that to you. Part of that is working with stakeholders, Representative Nuccio, to get that input so that, to your point, it is something that everybody is comfortable with. But that's something that we are currently developing, both from the executive branch and also, like I said, with the different stakeholders that are affected by the CFC program.
Okay, I hear what you're saying, and everything, but I think part of the concern is what we thought, what we were going towards, which was having people stay at home. That was the push that began about 10 years ago, probably, was let's have them stay at home. So the question is, when did we make that pivotal change? But I do understand that everybody's services are not the same. But then it should be reflected in the cost too, because everybody shouldn't be pulling all the same thing. But if we are just paying for the PCAs, then that would be sort of understandable. But again, when we should also be looking at what is the cost for us to keep them in nursing homes, and do we have beds for them? And we don't, because the other meeting we had the other day, we don't have any beds. So we're going to take people off of a program that is working. The programs that we want them to go to, we haven't even built up. So we're a little premature in rushing to make these adjustments. And it just, I understand the increase. When I looked at that chart for the increases, it reminded me of special ed. That's about how much it's been growing in special. What's going on in the air? I think it's very interesting. Things are shifting in a lot of different areas. But in order for us to be secure, we have to know what are we going from and what are we going to. And then we need to know what is it costing under one, which you're starting to unpack, but what is it going to cost us on the other, so that 5 years from now, we're back here scrambling again. So
So
I appreciate what you're doing. I appreciate it.
Thank you, Representative Walker. Let us take that back to Jalmar and Christine's point. We'll do the FAQs, but I think us identifying for you all of the other services that could be provided once it moves to the waiver will help answer some questions, and we will also provide the costs associated with some of those services. So we'll try and go back and give more detail to help answer the questions, because they're valid questions.
Yeah, thank you. Thank you very much. I'm sorry. Go ahead. I'll stop.
I would just add in too, I'm concerned. I respect and appreciate that there's going to be stakeholder meetings, but it feels like those should happen before this proposal is made, so we know where we're going. Because right now,
I agree.
No one knows where we're going. And I am uncomfortable saying, sure, let's do it, in the hopes that it works out, versus having a concrete plan of what this is going to look like.
So Representative Gilchrist, that's definitely understandable. And again, this is something that we're currently working on. I will take this back to your point. to both of you. And we will take back these questions so that they know, people who are above us know the comfort level that you guys are expressing, and so that we can also get back to you guys with the answers that will satisfy your concerns. But we'll take these back. That's something that we do need to work with our partners over at OPM and the governor's office.
Great, thank you. All right, I don't see any other hands. You can keep going.
Okay. So we did have 3 other questions in relation to CFC. Please provide data showing historical trends for home and community-based services versus institutional settings, costs and numbers served fiscal year 16 to present. So Christine, do you want to talk to this? You want to summarize?
Yeah, so this is I think we tend to share this each session. These are kind of our rebalancing numbers. We provided a link to the rebalancing report that gets published every year. So Connecticut as a whole, with CFC or absent CFC, has an HCBS and an intent to rebalance, which means more people and less money ideally are put into long-term services and supports in the community than institutional settings. People have the settings of choice and how their Medicaid dollars are spent for their long-term care. This reflects kind of our percentages and where we've been. We've increased access to individuals in the community. We have 71% are receiving long-term care in the community. And that's those, and there have been concerns from the advocates that this will disrupt our rebalancing. There's no intention for that, right? Connecticut's commitment to rebalancing and HCBS is probably stronger than ever. And this change in how the service is delivered will not have an adverse effect on rebalancing. And we will continue to hopefully keep that trend up where I think our ultimate goal is at 85% rebalancing. But right now we're at 71%.
So these numbers are a little confusing.
Okay.
When I'm thinking about this, the receiving care in the community and then receiving care in a home, right?
Sure.
So if, I'm sorry, a lot of numbers on here. So
yeah,
we're saying that 71% of Medicaid clients are receiving care in the community, but then we're also saying that 60% of them are receiving care in a home. Those numbers don't make it, would be 100%, right? So how are we at 100?
No, I think it's 2 different values. So 71, the way we categorize LTSS in like the Medicaid member is at institutional level of care. And are they receiving that care in the community or in an institutional setting? And currently 71% of our individuals that are eligible for long-term services and supports are receiving those supports in the community. The 60% is the expenditures. So one's a count and one's a cost. So they're not the same. So it's showing that although 61% of the population, 60% of the budget is used for that population. So that's the cost effectiveness of HCBS.
Okay, so 71% of our eligible Medicaid clients for the long-term care are receiving benefits at home, and
Yep.
it accounts for 60% of our cost.
Of the long-term care costs.
Of the long-term. And then the secondary one is, what is the by comparison since?
Let's see, since 2000, the proportion receiving care has increased from 41 to 60.
See how it doesn't match the above? That's what I'm not following.
Fiscal year 2000.
So it's just, we're adding 3 more years and the number drops down significantly.
Let me see, by comparison since. Let me just review how the 2 thoughts there. The state fiscal year 25 is probably what's most critical. I don't know if an additional point was trying to be made about our data collection, but maybe because someone asked for 16 data.
Yeah, I don't know.
Yeah, we'll sort that out. Please trust that the 71% and the 60% is the count and the expenditure. We'll clarify the second paragraph.
Okay. What makes up the other 40% of the expenditure? People who are in long-term care?
Yeah, long-term care. for 29% of the population, right? So they're in an institutional setting.
Okay. You don't have that in dollar amounts, do you?
Yeah, we do. It's actually in the rebalancing
in the
report.
report,
Yeah,
okay.
it is. It's staggering, and it shows. It actually shows it over multiple years. It's a fantastic report that's pulled together every year by our partners over at OPM, taking in a ton of information and data points. It's a great report.
Does the report illustrate does it project where we would be with institutional care should we have not done the rebalancing?
So Nicole Godburn's team we have a document with a long-term care long-term care analysis report that says absent interventions and with interventions, and interventions are a rebalancing in our programs. But I don't know, Nicole, I don't want to speak to your data on that.
Thanks, Christine. Nicole Godburn, Fiscal Manager, Reimbursement and CON with DSS. We can share the links to that report. It shows, to Christine's point, the pre and post interventions that might address the question that you have. So we can pull that information together and send that over, and then we're happy to have follow-up with you if you had additional questions after.
That'd be great. Thank you. Because I hear what, Christine, I hear what you're saying when there's a commitment to continue rebalancing. It's just if we cut off the CFC program, where will those people go?
Yeah. So our HCBS suite of services serves over 40,000 members at this point, right? So we have multiple authorities and multiple programs that serve the HCBS space. So those 40,000 members are served and cared for. You'll see in our next chart the breakdown of individuals that it's kind of like a funnel of services, right? Not, limiting the access to the state plan entitlement, right? So the CFC, which is an entitlement and their only choice, because we have weights on those other programs. So you guys sit every time I have a waiver hearing, you ask, what does it take to clear the wait list and how many years are the wait list, right? So we have this position where we have these other programs with weights, but CFC being an entitlement, everyone just gets to come through the door and there's only one service available. So when you see down, there's just over 3,000 individuals that aren't tied to a waiver accessing CFC. So those individuals would then be placed into an appropriate program or a new waiver to serve them. And then we would address the people that would have been applying for the entitlement and better right size them into the other waivers and address that overall concern of this wait for HCBS and what does that look like. So it's what I just want to say is having CFC no longer available and making the service available in the waiver. A lot of people are being met by that. There's about 3,000 people that we would need to place and find a home for either in a new waiver or an existing waiver.
Dave, can you scroll down so that they're able to see the chart that Christine's referencing? Christine, is this the chart?
Yeah. So this is a high level overlap of home and community-based services and community first choice, where half of our individuals are what we call standalone, which are accessing it through the state plan entitlement only. They need to be Medicaid eligible for that and have access only to the self-directed PCA under the entitlement. The other half are tied to existing HCBS services and supports, like we call the waivers, the 1915C, and they use CFC in conjunction with those other services for a holistic plan of care. So that's a high level kind of overlap of kind of the DDS individuals that are using CFC with their waiver, then the DSS waivers that we operate, and then community first choice standalone is that orange piece. And if you go to the next chart.
Wait. So the blue is DDS waiver plus community first choice?
Yes.
Okay, and DSS is just the agency part. It's just the non-community first choice.
No, so I'm sorry, the green portion would be individuals that are on the acquired brain injury waiver, the Connecticut Home Care Program for Elders, the PCA waiver, the waivers we operate. So HCBS we have DDS operates 3 waivers, DSS holds the 6 waivers, and then Demas has the 1 waiver. This shows the DSS waiver saying that 35% of people that are accessing the self-directed care also already live inside another waiver and have another authority already supporting their care plan that they're using coupled with CFC. So when we put it back into the waiver, so we made that decision because of that 6% match, we pulled self-direction out of the waiver 10 plus years ago for that enhanced match. We would put it back into the waiver, and they would just continue on with their care plans and their service delivery. So half that pie has a place to land. The other half would need to be identified on an appropriate program or authority to support their services if we transition off of CFC.
But there might not be room in the DDS and DSS waivers, so they might get put on a wait list.
No. So if there's that is what we want to make very clear, and we've said this in testimonies, and this will definitely be in the talking points. Any active participant on services will not have to wait. We will expand capacity in the waivers, or we will establish a new waiver if they don't fit into one of the existing waivers. Because, like, as you know, we talk about acquired brain injury, PCA care, or Connecticut Home Care Program for Elders. If they don't fit into those criteria, we'll either look to expand the criteria under those waivers or establish a new waiver. No one who has been utilizing the benefit for their care will have to wait for care. That has been echoed by our commissioner repeatedly.
But that would be that. But obviously, new folks coming in, they would have to wait, or they could have to wait.
Yeah. So, well, and just like they wait for the 1915Cs, they would have to wait for our. But part of this conversation and part of this dialogue that we're having is, what do we do with the money that we're saving under CFC transition, and do we get to afford more opportunity under the existing, well-established, well-run HCBS programs?
But I mean, okay, so but then specifically, right? So we could do all of that, I guess, but there would obviously be a wait list. So we would be that would be the main purpose of the program is to establish a wait list to achieve savings. How would we structure people on that wait list though? Like how are people prioritized in terms of what, is it first come, first serve, or is it based on acuity?
So Senator Lesser, we are looking at best practices. I mean, it's a wait list, what are the best practices? But we're very concerned about the people that would be on the wait list and how we're proposing to implement the wait list. We do have a working group looking to see what are within the agency, looking to do research as to how wait lists are run and what are the best practices that are happening. We've looked at how DDS runs a wait list for one of their programs. And so we are looking across the country to get examples of how wait lists are used in waiver services such as this. Ideas have been tossed around in terms of necessity, in terms of like needing the services, more complex needs. We've tossed that around. So we're still in the process of pulling together the mechanics of how the wait list would actually work. And we invite, feedback as we're pulling together those plans. Okay.
So I don't mean to beat a dead horse, but during the initial approach hearing on this, the commissioner did indicate some preference to folks with lower acuity over folks with higher acuity, or was it the other way around? And so did she? I'm not asking you to contradict your boss, but did she get ahead of her skis? Is that something that just hasn't made, that decision hasn't been made, or what is, I just was curious what she was talking about there.
The decision hasn't been made, Senator Lesser, but what we're trying to do is to make sure that people that need the service, to the degree that they need it, can actually get the service. We're still pulling together what the wait list would look like. I think, I don't want to speak for Commissioner, but I think what she was trying to articulate was that we're looking at different ways in which we can administer the wait list. I think she was trying to give you examples of how we were thinking about administering the wait list, but to the degree that it hasn't been decided that this is the process that we are going to use, that's still being discussed.
And is there any indication, any modeling of increased? I know this was a subject yesterday, and I don't mean to bit of, but is there, right, any barriers to community-based services could lead to folks going to other avenues like nursing home-based care? Do we have any modeling of what that looks like, or at what point people do go in there or not? I mean, that's right. The advocates are arguing that this is going to raise costs insofar as it prevents people who, from getting needed services. And I don't know, I don't know if we can model that approach out.
So the department is working in iterations of the differences. It's still a work in progress. It is hard to get that type of information and model what that looks like. So it's something that the department does have on its radar, but we do not have something that we could share at this time in regards to that. Christine, did you want to say something to that, or Nicole?
I just would like to share that, HCBS and nursing facility is not typically a one-to-one, right? So in our great state of Connecticut, we have made a tremendous commitment to help individuals age in place, stay in their home, individuals with significant disabilities, to remain in their community and choose how their Medicaid services and supports are offered. On a national level, there is research trying to kind of figure out how much have we truly diverted and delayed institutional care, but it's very hard to kind of wrap around that exact value. We know that we have a higher quality of life by being in the community. You're tied to family, your cultural needs. All of that is what are the tenets of HCBS. And Connecticut has done a remarkable job over the decades, through appropriations, through the Home and Human Services Committee, and just our advocates, right? They're relentless to make sure that people have choice. This by no means, this by no means will drive people into institutions, right? Like, that's not the intent. The intent is to be able to adequately serve everyone as they need it. There will be waits, but we've always had waits. And then we have a home health benefit for individuals that are eligible that need to access that. And there are going to be resources available. But I do think it is very hard, Senator Lesser, I think to give you that number. And they are doing that on a national stage as well. They're trying to figure out that number.
Mm-hmm.
Well, I hear that. I guess, as appropriations committee, we need to balance the state's budget. And if we are doing something that, is penny wise and pound foolish and actually raises costs for the state, that's obviously something we should be, really careful of doing. I'm not saying that that's what it's doing, but I'm concerned, especially because we've heard a bunch of advocates who've argued that this will put people into more expensive nursing home care, which, if that happens, that would be bad. If that's in fact what that's not what I know that's not what the department is intending to do. I'm not saying that that's your intent, but we got to just be very careful that that's not the you squeeze in one area, then there are going to be additional expenses somewhere else.
Yeah. So then, Alessa, we're fully aware of that, and that, to your point, is not the department's intent. But we will try and take that back and add that feedback to our FAQs to make sure that we're able to be responsive, because that's a valid question. The department is working on something like that, an analysis to be able to concretely get to that. But again, that's a question across the nation that states are dealing with to try and answer.
Got it. Okay. Thank you, Madam Chair. I went up.
Yep, great. Thank you. Rep. Nolan, go right ahead.
Thank you, Madam Chair. And I'm sorry, when I'm explaining this to some of the constituents, when I do a PowerPoint where I show this PowerPoint to them because there's a lot of questions in regards to it. Just want to make sure I'm not confused with the numbers that are on the screen at this time. Those do not include the waiting list. These are just active cases of people that are presently getting services.
That's correct.
And is it waiting list for each of these waivers, or is it one waiting list period?
Waiting lists are waiver specific.
Okay. So we have numbers on how many people are specifically waiting for each of these?
Yes, we could provide that.
Thank you. I appreciate that. Thank you, Madam Chair.
Thank you.
Okay. Question 5.
Okay.
Okay.
Let me know if it, go ahead, sorry.
Go ahead, Christine. Does this policy change consider inclusion or increased support for day programs? Do you want to talk about that, Christine?
Yeah, so this kind of speaks to some of the stuff we were just sharing about how CFC has primarily a single service, right? They have self-directed personal cares that help individuals. The connection to day program, so day program is not a service currently offered under the Community First Choice program, but if our individuals move into waivers, they may have access, and that again is another thing to offset potentially the need for self-directed care, that they would be accessing those other suites of services. So if they move into a waiver that offers an adult day center or a day program, then they would have choice to say, okay, I'm going to use less self-directed and take this other model. So for individuals that will be in a new waiver, will have to and want to access adult day, if that service is available to offset their PCA needs, they'll be able to choose to do that. Right now, there's no choice for individuals in that standalone component that we talked about. So when we talk about CFC participants that are not don't have access to a waiver. When we talk about waivers, what we're doing is we waive certain state Medicaid rules and we get to offer enhanced services and supports. The individuals in CFC standalone don't have access to those enhanced services and supports that other part of the pie chart do. By moving them into the 1915C, we potentially have this opportunity to offer more access to those enhanced services. So inclusion or increased support for day programs, it is potentially a good outcome for more individuals to have access to that service.
Does this, maybe this was already answered, does the governor's budget proposal, since it is ending the CFC entitlement, does it build in funding to these other waivers?
Anne Marie, do you happen to know that off the top of your head? We may have to go back. It's not clear. I don't think it does, but Anne Marie, do you know that question when you built the model?
Yeah, the proposal does include the cost of transitioning people from Community First Choice into waivers. It does not include the cost of adding slots in addition, like for new people who are not already on Community First Choice.
Okay, thank you.
Okay.
No new slots at all?
The governor's budget did not include new slots in that analysis, but we are recently looking at the cost of adding new slots.
How many people sign up for the CFC program monthly? New people?
I think we'll have to come back and get that information to you. I don't think we have that readily available.
Okay, because I'm just wondering, I mean, I am not someone that does that kind of math, so maybe OFA can help too, just to understand, like, how many people are we talking about who might be applying for these waivers? So how many slots would we need to potentially build?
Yeah. I think the team is doing that analysis now. Once that's available, we'll provide it.
That's not my bailiwick, so thank you.
Okay, so we have questions 6 and 7, which I think we touched on, but I'll briefly read. How many PCAs provide services under CFC? And in a given month, there could be 16,000 active PCAs. And to our discussion earlier, we will lose the enhanced federal match of the 6% by moving to the waiver. Okay. Next is the section that we've labeled the PDPM, the patient-driven payment model. Please explain why this model significantly reduces Medicaid payments to nursing homes. And so I will give the floor to Nicole Godburn. Do you want to summarize this for us?
Sure. Thank you, Deputy Commissioner. So once again, Nicole Godburn, Fiscal Manager, Reimbursement and Certificate of Need with DSS. To summarize, back in October of 25, Centers for Medicaid and Medicare Services, CMS, stopped supporting RUGS, which is the Resource Utilization Grouper, which was the information, the federal information that was gathered from nursing homes up to CMS that we as a state and many other states used to calculate the acuity-based reimbursement that we pay to nursing homes. So when CMS stopped supporting that, they transitioned to supporting a new methodology called Patient-Driven Payment Model, PDPM, which is a very different way of classifying residents. RUGS was really a volume-based way of classifying residents. So it was really based off the number of services provided to residents, whereas PDPM focuses in on classifications that are really targeted on the clinical need of the person. So it's a very different way of doing that assessment. So based off of those differences and based off the requirement of the federal transition, we as a state, all states that pay this way are required to transition. So most states have already transitioned or are in process of doing that transition. So Connecticut, we are targeting July 1st as the date of implementation. And because it's a different way of assessing the resident, that is really fundamentally kind of shifting that payment methodology and why we're seeing the difference in payment. And as we get further on in our presentation, we have more information about how we're going to be doing those targeted assessments of where the funding will go.
Are you able to show the baseline impact of PDPM on rates by nursing homes?
Yes, the short answer is yes. We are currently, because we have the CMS releases PDPM data quarterly, so we have just received the most recent quarterly information from CMS. We also, with the release of the governor's budget, have the ways that funding will be targeted. So we have a model that we are currently updating, showing a home by home look at the impact to each nursing home. We should have that information ready within the next several weeks, and we will be doing, if you recall years ago when we rolled out Acuity, we did a whole host of public hearings, we did webinars, we were very public in how all that information was shared, so we are going to do the exact same process again. And so once we have the model again up to date in the next few weeks, we will start getting all that information out.
And that goes to the next question. How will the new 13.1 million in state funding be used to support homes?
So just referencing the chart quickly above, the investments are going to be staggered over 3 years, year 1, year 2, and year 3. Part of those investments include new money, 13.1 million, that will be targeted towards Medicaid utilization. This is a way to help incentivize access to Medicaid members in nursing homes. So nursing homes that are 75% or greater and with Medicaid members will be able to receive funding from those pools. And that's just really a way to, one, help expand access to Medicaid members, and then 2, that money would be then targeted back into the homes to help improve quality for our members. So we think it's a good policy. And I see Rep. Nolan, you have your hand raised.
Well, first I want to ask Madam Chair. I got a question about care attendants pay. Would this be an error to ask about that, or should I wait?
You can ask.
Yes, care attendants don't necessarily, I think in the nursing home setting, certified nursing aides. Is that what you're referencing?
For the Community First Choice program.
That I would have to defer to Christine on that question.
Okay.
Rep.
Christine,
Nolan, can you repeat your question?
yeah, I just wanted to know about Community First Choice pay, you know, they're when they pay in the care attendants. There was a couple of questions in regards to you know, delay of pay, or because the person in home takes on the supervisory and everything to do with that care attendant, that there was concerns with the delay in pay for them because of the new, I guess, financial management service that handles it. Is there something being done about that?
Yeah, so Representative Nolan, thank you for your question. We do discuss our FI GTI later on in the presentation, but we have been working with the FI to make sure that they understand the intricacies and the billing and making sure that payments are going out so in a timely fashion. So we are working with them to make sure that those issues don't continue.
Okay. If Madam Chair, if I can ask, can we get something in writing saying that that's being taken care of or how it's being taken care of?
Sure. Christine, do we already have something that we've pulled together to notify our stakeholders what's happening?
So we've made some public comments. I can circulate that. I could talk to our comms team. There's no, to assure everyone, there's no active payment issues currently. There was an event in the past, but there's no current non-payment issue going on with the fiscal intermediary or the care attendants. But I can get what we released, DC VARs, and share that with the legislation team.
Thank you.
Thank you. Thank you, Madam Chair.
Okay. Okay, what is the net financial impact to the nursing home system? Go ahead, Nicole.
Great. Thank you, DC. So this chart here will show the net financial impact to the system. And as previously mentioned, we are looking to make reinvestments, so to get money back into the industry. And as previously mentioned, we'll do that over a 3-year phase-in transition. And here you can see in each of those years the monies that will go back into the system. And we've also broken out the state share below. But just like to specifically note some of the policy goals where, again, back to the Medicaid utilization pool to support homes and access to Medicaid members. And then we also will be funding in the 3rd year the quality performance pool. Many years ago, the legislature tasked us with creating a quality program for our nursing homes, and so that they could tap into funding to help improve quality within the buildings. So we had created that model, and very happy to say that for year 3, we'll be using some of those reinvestments to fund that, to help reward nursing homes for making those quality improvements. And those improvements are based off of consumer satisfaction surveys that we conduct on every nursing home, and the federal CMS quality measures that they rate on nursing homes. And we have more detail on our website, and we're happy to share that link for that. So if any questions?
Okay. Thank you, Nicole. Next, we will move into the area of PL 119-21. Please detail the policy changes impacting the fiscal year 27 budget, including new costs and anticipated savings. And so the governor's budget reflects Medicaid savings of $22.5 million based on the assumption that 65,000 Medicaid enrollees will lose coverage by June 30th of 2027 due to work requirements and changes in non-citizen eligibility. DSS continues to evaluate how many enrollees the department may be able to automatically, predetermine to be compliant or exempt, and how many need to provide additional information to maintain eligibility. For the purposes of the governor's budget, it is assumed that approximately 56,200 will lose coverage as a result of the work requirements. The budget also assumes approximately 8,300 non-citizens will lose Medicaid coverage effective 10/1/2026. Due to new restrictions that remove eligibility for refugee asylees, parolees, victims of trafficking, victims of domestic violence, and Afghan and Iraqi nationals with special immigrant visas. The governor's budget does not assume any savings associated with the increased frequency of Medicaid eligibility verification or the Medicaid changes to retroactive eligibility, both of which are effective January 1st of 2027. As a result of the eligibility changes, the governor's budget includes $3.27 million, excluding fringe costs, to support 50 new positions. And that speaks to question 13, which we were asked to detail the positions and how we would hire. And so the department took some time to identify the position title and the number of positions. I do want to preface this as saying that as the needs arise and as we're hiring, we reserve the right to make changes to, what is laid out here in this chart. And so I will move on to please detail policy impacts supported by Special Act 25-1, the November special session reserve funds. And so the department did provide a table to speak to the activities for the Special Act funds. Our next section is in regards to the substance use disorder waivers reserve line item. Please detail all changes made to the SUD waiver reserve line item, including a brief statement of purpose of funding transferred to each agency. And so I will turn it over to Bill Halsey to discuss.
Hi, good morning. The substance use disorder demonstration waiver has a reserve account associated with it. So if any of the new federal dollars coming in exceed costs, it goes into that reserve account. If you scroll down just a little bit more where it says proposal, you'll see where we made investments within the SUD service system right there. Thanks. And so we increased our Medicaid rates for the substance use disorder residential programs quite significantly, actually, for the adolescent one. And then DMIS, DCF, Judicial also made investments within their systems based on the reserve account.
Okay. How does the Consolidated Appropriations Act of 2023 impact the SUD waiver reserve account?
I'll take this one too. So again, this is an opportunity to better serve individuals who are incarcerated. This is a requirement, the Consolidated Appropriations Act. We're anticipating some additional costs, and so we put some dollars into this reserve account to account for new services starting on July 1st related to individuals that are incarcerated.
Okay. Thank you, Bill. Our next section is MedConnect, and I will allow DC Hadler to take the floor on MedConnect.
Thank you, DC Vars. Hello, everyone. I'm happy to be able to provide a little bit more information about the MedConnect program and the questions that were posed around current enrollment and other levels of information. So currently there are 3,600 people enrolled in the MedConnect program, and 58% of them or so pay a premium. The proposal on the table here, if you recall, is to pause the expansion that was initiated this past year, where we did increase the income and asset limits for enrollment into the program. And it's currently set at $85,000 for an individual or $20,000 or $30,000 assets, which is an increase from prior levels. Because we are looking to cap the levels of income and assets where they currently are, we don't believe that any current recipients would be impacted by the proposed change. We will note, though, that the proposed expansion of MedConnect under the existing statute is projected to include expand enrollment by about 2,500 individuals with an overall gross cost of $16.6 million, about half of which is state share, when it is fully annualized by fiscal year 2030. A little bit more detail on the current costs. The typical per member per month cost of an enrollee in MedConnect is $650, and the average premium offset is $90. So it is a per member per month cost of $560. And I also just wanted to quickly note that there was an additional question about whether the premiums that were being charged would be sufficient to cover the costs of new enrollees. We continue to re-examine our fiscal assumptions, but our preliminary analysis does indicate that it is likely to continue to not be sufficient. Premiums will not be sufficient to cover the full per member per month cost due to the way that the income is counted and excluded and when the premiums kick in the program. So the cost estimates are, I will say, preliminarily correct. We are going to revalidate and ensure that the numbers that we have put here continue to be accurate. I also do want to quickly highlight that because asset limits are increasing, that is a different variable. So some folks could have lower incomes and therefore smaller premiums, but they may now be able to enroll as the asset limits go up if they had previously not been able to qualify due to the asset limits that were in effect.
Okay. Thank you, DC. Next section is the immediate care facilities. Nicole, has DSS reviewed the regulations that limit ICF payments due to allowable cost caps?
Thank you, DC VARS. Yes. As a reminder, in accordance with Public Act 25-168, the department was required to review the regulations regarding ICFs, in particular, the inflation cost limitations on the direct care component of the rate. So we are in process of reviewing and updating those regulations to be in compliance with the Public Act. We're really at the end of our draft process of updating those regulations, and we'll be going through the formal submission process shortly. So yes, we are in process.
Okay. And can you answer the question regarding the anticipated costs to modify?
Based off the most recent cost report filings, which are for fiscal year 2024, the estimated cost to remove that is 2.4 million and state share is 1.2.
Thank you. Next, we will move on to the Medicaid provider rates. The department had provided a rollout of the provider rate increases in the table below. Next, the next question was, what does the annual rate review process look like? Is there a schedule? And so the department did provide 2 links to the rate study, phases 1 and phases 2. Is there a rate?
I do have a question on that, but going forward, there's not a plan for, like, we have these, my concern is we have the studies, but now how many years will go by and there won't be a rate review? So has the department created a timeline or a plan to continuously review the rates and update them in accordance with what was done in the phase 1 and phase 2?
Yes, but go ahead, Nicole. Do you want to speak to the plan?
Thank you, Deputy Commissioner. Yes, we did take one of the major recommendations from the rate study to develop a rate evaluation process. We have shared that evaluation schedule as an attachment to this document. It's quite a large document, so it is shared as an attachment, which will look at every aspect of the Medicaid program over 5 years. And then when we get to the end of the 5 years, it's kind of rinse and repeat. So that will, so every aspect of the program is reviewed and evaluated and touched. So that is underway. The attachment is there, and we will be building out additional information and more detail on the DSS webpage to make that all publicly available. But yes, that is included in this document.
Okay. The next section we'll be moving to is the medication administration. Please provide total costs for med admin services at the initial visit rate and 2 subsequent visit rate and the associated utilization of each. And so the department did provide a table based on procedure codes that reflect the dates of service for fiscal year 2025. The next section will be moving on to community health workers. And so I think is it Bill or DC Hadler that wants to discuss the community health workers in regards to the reimbursement for community health workers?
Happy to start, DC Vars.
Thank you.
So as we say here, we look for ongoing opportunities to invest in community health workers. We have a couple of examples within our PCMH Plus program. Some of the FQHCs hire and employ community health workers. Our Medical Administrative Service Organization, CHN, hires and employs community health workers. And recently, DSS awarded funding to the community action agencies to hire CHWs to do community-based outreach and education. But we look for ongoing opportunities to invest in that space as well.
Okay, so the next section discusses the current services updates. The first question was, please describe caseload and cost trends contributing to the proposed reductions in TFA and SAGA. And so we really tried to provide a detailed response. And so as described in the governor's proposed budget, it is reflective based on current trends. It's important to note that no federal TANF block grant dollars lapse and no TANF funds are carried over or returned to the federal government, even with lower re-enrollment within TFA. With the exception of funding to support OEC's Care for Kids program, TANF block grant funds are deposited directly into the resources of the general fund. The fiscal year 2024-2025 budget included 3 significant TFA program expansions. One was raising the earned income disregard, the second was doubling the asset limit, and the third was increasing the time limit for 36 months. As a result of these expansions, TFA caseloads grew by approximately 5% in 2024. The current budget appropriation for TFA assumed caseloads would continue to increase at an average of approximately 5.5% per year in fiscal years 25, 26, and 27. However, what we saw was that TFA began to decrease significantly in January of 2025. So between December 2024 which is the current budget appropriation levels, in December of 2025, when the reestimate for the governor's recommended budget for 2027 was completed, caseloads dropped by 16%. Despite the downward trend, caseloads and expenditures, the governor's recommended budget assumes costs and caseloads will remain flat for the remainder of fiscal year 2026 and increase by 3% in 2027. Given the sustained decline in caseloads and expenditures since October of 2024, the recommended adjustment is to remove $21.4 million from fiscal year 2027 TFA appropriation, which is warranted as it more closely aligns with the funding levels with actual caseloads and expenditures. And so the next paragraph, we will address SAGA and SAGA.
Actually, I have just a couple questions on that. So if I'm hearing you correctly, we estimated higher than we needed, right? We had a decrease, but you said we don't give any of that money back to the federal government? Like,
That's correct.
How does that work? How are we able to keep money that we didn't need from the federal government?
DC Hadler, do you
Yes,
want to?
happy to help jump in on that one. Thank you, Rep. Nuccio. So the way that the current structure of our TANF block grant functions is that the funding is deposited into the general fund and is allocated not just to DSS, but to many other sister agencies who administer TANF funded programs. Those dollars are on the back end claimed as necessary to be assigned to the TANF block grant to ensure that all funds that are associable with the TANF block grant are utilized. So even if we see a decline in one area where we had some expectations of what the budget would be, there is a substantial amount of funding that is TANF eligible and that we identify and track in accordance with TANF rules every year. So we ensure that through that process, we ensure that none of the federal funding is ever lapsed. So that's what's happening here. This is, as DC Farr has outlined, within the TFA line, within that specific cash assistance program, we are adjusting the projected enrollment based on the most recent trends, which are downward, when we had expected them to continue to rise slightly in the last budget.
So are you saying that we have offsetting increases somewhere else to fully expend this money?
It's not necessarily increases. There's basically more programs that qualify for TANF claiming than there are federal dollars. So if we see slightly lower expenditures in one area, we identify other funding that can be associated with either the federal block grant or our associated maintenance effort state funding that is required in order to maintain the block grant.
And all of these programs are run with the federal regulations, right? Connecticut doesn't do something outside of the federal requirements.
No, we are fully compliant with federal requirements.
Okay, so can you, this is a question I think one of my colleagues, I don't know if she's on the phone right now, can you tell us, can you give me us an exhibit that would show, like, you just mentioned that TANF has multiple different agencies that it falls under. Can you give like a summary of all the different places that TANF is used throughout the budget? So we could see that,
Yes,
like,
of course.
see the whole program overall.
We have a TANF state plan and lots of reports that I do believe routinely provide, and we can highlight those and get them back in front of you, recognizing that they're not always in the same place all the time.
Yeah, I appreciate that. Thank you very much.
Thank you. Rep. Dathan?
Thank you so much. Just really wanted to ask about TANF. Do we know how many cases would be eligible for an extension beyond the 36 months? Because federal law does let us go to 60 on this, and a number of states do. Connecticut is an outlier here, and well, not an outlier, but we're definitely not in the leading pack when it comes to TANF dollars. And I'm just kind of curious to know how many cases that are exiting at 36 months that would be eligible to continue on for a longer period. Because I would imagine, beyond the 36 months, it does kind of tail down. But I'm kind of wondering if those dollars, instead of reallocating them somewhere else, might be useful to, and let's be kind of clear, this fund was set up for typically single mothers that are trying to get back to the workforce. And I think sometimes when you have young children, this takes longer than you think it's going to organize childcare and all the other aspects. And I'm just kind of thinking that other states do provide this benefit for a longer period of time. Or if we had some sort of decreasing benefit so that these families could stay on. I just would love to know what that might be, DC Handler, if you have, Hadler, if you've thought about that at all.
Yes, no, it's a very good question. It's something that I will first note that not only do we have the new 36-month limit, which did bring us much more into the mainstream. We had been quite on the lower end of time eligibility as a state until we made that adjustment. And not only do we have 36 months, but there is the potential for 2 6-month extensions. So you can go up to 48 months. We do track both participation within the state and also a federal tracking. Because people can receive benefits in other states as well. So some people do hit the 60-month total aggregate limit on the federal side. I also will note that there are families and individuals that are exempt from those time requirements as well. And about half of the enrollees are currently exempt entirely from those limits. We can look at how many people are exiting at 36 months or at 48 months and provide that information back to you so that we can get a little bit better sense of how many people are sort of running out of the clock based on where it's set now.
That's wonderful. Thank you so much, DC.
Sure.
Based on your expertise and experience, why do you think there is such a significant decline in caseload? Why do you?
Yeah, thank you for that question. I will say that this has been a extraordinarily long-standing trend across every state in the country when it comes to the cash assistance programs that are funded under TANF. Caseloads over the past 20 years have declined multiple hundreds of percentages down to very low numbers where they sort of are today. I think that one of the major challenges, and we see this because people do apply for assistance and cash assistance, is that they're often over income. The income threshold for eligibility is quite low for this program. This is consistent with how other states structure their program as well. But that does make it a challenge for people who are looking for supports, but can't necessarily qualify because they earn a little bit of money, but it's a little bit too much to receive TFA. The other thing that I will just note, and I don't have a particularly strong idea of exactly why it is occurring, but we have seen a steady and decline decrease across all of our cash assistance, as well as the SNAP program dating back to the beginning of 2025. There has been a noticeable decline across all of those programs. There's obviously was the change in federal administration, people's reactions to that. That could play a factor into it, but it is just something that we are observing and don't have, concrete evidence to be able to say that it's one thing or another.
Okay, thank you. And I think I know the answer, but the income limit is set by the federal government. Can we change that?
We can. There are upper bound limits as to how TANF dollars can be spent. There is maximum thresholds for TANF programs. There's only a little bit of flexibility at the higher end, but income eligibility within that framework can be set by states.
Okay. Would you be able to follow up with just some quick info on what our income limit is and what we can go up to?
Yes, we can do that.
Thank you.
And so DC, can you speak to Saga? Basically, I think you talked about, the reduction. It's the same within Saga as well.
Yes, and this is again sort of mirroring that trend that I referenced, which is just sort of an across the board decline in enrollment in our cash assistance programs for the past year plus at this point. Obviously, we are correcting our budget projections just in alignment with what we are seeing. And again, I don't have a particularly single point of item that is driving the decline, other than to note that it has been consistent and across the board across these programs since January 2025.
Thank you. So next we'll move on to the section of the Connecticut Children's Medical Center. The question was in relation to the payments that we've made, and so including Medicaid and DISH. And so we did outline those payments in the table below. The next question is, does DSS have concerns regarding including CCMC under the hospital tax supplemental payment distribution? And DSS agrees with the governor's proposed budget adjustment that would keep CCMC exempt from the hospital provider tax and outside of the supplemental payment distribution. Next section is the hospital supplemental payment section. And so there were two questions in relation to the hospital subs. Please provide an overview of the hospital settlement timeline, current negotiations, and related funding. And so the department did provide a brief overview of where we stand in those discussions. And the next question was, please explain the different budget components of the current settlement, provider tax, Medicaid rate increases, supplemental payments, and match on gross appropriated supplemental payments. And the department provided a brief overview of how that works as well. The next section, we will move to the federal budget. And there was a question regarding how is DSS impacted by the Consolidated Appropriations Act of 2026. We've outlined about 6 areas in which we would be affected. One area is the disproportionate share, the DISH reductions that would happen. We've outlined streamlined out-of-pocket provider enrollment costs. We've also outlined PBM reforms. maternal health, and the block grant funding. And last but not least, we will end with our GT independence. This is our FI. There were questions related to that. And so the first question was, please summarize the purpose of the DSS contract for GTI. Christine, do you want to go ahead and summarize this for us?
Sure. So a few years ago, we went out to RFP for a joint FI across a number of our agencies that use self-directed services. So that would be us, DDS, and Aging and Disability Services. As you guys may remember, Allied was our old FI and a company called Sunset Shores. So we went out to RFP and GT Independence was selected a few years ago. So we have a joint agreement with DSS, DDS, and ADS for fiscal intermediary services. And what essentially our fiscal intermediary does, the bulk of their work is to help our self-directed employers navigate what it means to be a self-directed employee. So in Connecticut, we are not joint employers. Our Medicaid members that elect to self-direct get their own FEINs. They have household employees. There's payroll taxes that need to be taken care of. And all of what we do is we provide the fiscal intermediary supports for our Medicaid members to be self-directed, consumer-directed employers. So the FI has a whole host of responsibilities, including helping them support managing their individual budgets, timely processing of the Medicaid claims and the payroll, onboarding of the self-directed employees, which is running criminal background checks and verifying work eligibility. They provide training and customer service, and they do the tax filings and generate the W-2s for the PCAs. So it's a heavy administrative fiscal intermediary support. So that is what GT does for us, the bulk of their work. There's additional parts of that where they do a little bit of MFP work and they do some provider credentialing for the waivers, but their biggest book of business is helping an individual be an employer to household employees. Next question.
Thank you, Christine. So the next two questions, I think, is in response to Rep. Nolan's question earlier about the recent events that have taken place with payments and the like. And so please summarize the recent issues DSS and clients have experienced with GTI, and please summarize any steps DSS has taken to address these issues. And so I think you can probably answer those two.
Yeah. So sure, and I think anyone that's been on this legislative body for a while, I think a lot of complaints came through when Allied was the FI, and now unfortunately we've gotten a lot of complaints with GT. I'd like to say it's the nature of the work is very complicated. They have been here just about 2 years. They've assumed full payroll responsibilities in the end of March 2024. We've had problems with their speed of onboarding, their customer service response times, and communications with PCAs. And then there have been these pockets of what we're calling events of non-payment issues. They do process $8 million a week of self-directed payroll. So in this, when, as we said in an earlier question, there's 16,000 PCAs at any given time that are active in a month. So their volume is tremendous. But anytime a PCA goes without pay, if it's 5, 10, 200, it's disruptive to that PCA. And we acknowledge that. But it is a very large volume of work. But they keep having the same persistent problems. And we've struggled to kind of get them to a performance level that we would want to see for a contractor. We're committed to continual improvement with our members, and we've heard the complaints. We certainly have heard the complaints, and we meet with GTI nearly daily on process improvements, how to have, if one problem comes up, is it a systemic problem? Was it a one-off? And what does that look like? And how do we kind of fix it moving forward? They are under what we call enhanced contract monitoring. It's a component of our of one of the features in the contract with them, where we could put them under enhanced contract monitoring, which requires a greater level of oversight where they have to report out their process improvements and demonstrate to us that they are kind of meeting our expectations. It is a significant responsibility. We understand that, and we don't take that lightly. We hear the concerns and the complaints, and all I can stress is that we are in continual process improvement on our part, how to be a better steward of our authorizations, our files, our program guidance, for them to best be the FI to support our individuals.
Thank you, Christine. And so Representative Gilchrist, that concludes the questions that were sent to us.
Thank you. Does anyone else have questions for DSS? Yes, Representative Martinez, go right ahead.
I had asked questions regarding the medication administration rate. And one of the questions I had asked was what the cost is per day for inpatient behavioral health admissions. What I was looking to find out is the subsequent visits where healthcare nurses are getting paid half the rate when people live in the same building. We're seeing more of those, and I am worried if those patients are no longer being picked up because the med admin rate is so low. If they're going into the hospital, I want to see a comparison of what the inpatient, what we're paying per patient.
Thank you,
or inpatient
Representative.
versus per day with the med admin rate.
Okay, thank you, Representative Martinez. Dave, I'm not sure if you can pull that chart back up. I think it might be question 20.
DC Vars, I don't think we have the inpatient behavioral health rate
Okay.
on the chart.
Right.
That is something that we would need to
We need
get.
to take back? Okay. We'll take that back and provide you a response to that.
Thank you.
Great, thank you very much. Anyone else? All right, I don't see any other hands. Thank you for all of this information. We will soak it in. We might have follow-up questions, but truly appreciate you all being here, all the information you shared and the work you do. All
Thank you so much. Have a good one.
right, you too.
Bye-bye.
Thanks.